Sidoni. Next slide. I would like, again, as always, but with thought, to acknowledge that we're hosting this session on the unceded and ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations, as well as the Métis Charter community of the Lower Mainland region. And we commit, as always, to ongoing learnings and understandings and caring for the land with respect and thoughtfulness. And wherever you are in this province or anywhere in this country, commit to also learn about not just the words of the land acknowledgement, but also what it means and why we're acknowledging it. So with that, this is province-wide rounds, a collaboration between the University of British Columbia Division of Nephrology and BC Renal, generously supported by industry partners and all of you in the health authorities, clinicians, administrators, healthcare professionals, all working together to help better understand and treat people living with and at risk for kidney disease. So today we're fortunate to have Dr. Mei Lin Bissonnette. She's a clinical associate professor in the Department of Pathology and Lab Medicine and an associate member of the Division of Nephrology. She's been a pathologist at our provincial lab based at St. Paul since 2015, so almost a decade, and is the director of the BC Provincial Renal Pathology Laboratory, which is, as I said, the provincial centralized lab for all kidney biopsies in British Columbia. She's also the current secretary of the Renal Pathology Society and has served as the chair of the RPS Education and Training Committee since 2022. Her research interests are diverse and include molecular expression of disease states, both in native and allograft kidneys, and she's leading several province-wide quality initiatives related to medical kidney biopsies. She completed her BA in biophysics at Johns Hopkins and then completed her MD PhD at Northwestern in Chicago. And in 2010, as part of an NIH-funded medical scientist training program. And then she finished her medical training in anatomical pathology and a renal pathology fellowship at the University of Chicago. So with that remarkable and diverse background, Mei Lin, I'll turn it over to you to update us about what we can look forward to with Provincial Renal Path Services.
Great. Thank you, Adira. So good morning, everyone, and thank you for coming for this update in the Provincial Renal Pathology Service. So I wanted to give a bit of a summary of what's happened and some of the highlights of what's happened in the lab in the past year, as well as some things that we're working on and some of the larger projects that we're looking to build both in 2024 and beyond. So first, I would also like to recognize the newest member of our team, Dr. Pune Dokuhaki. She's currently here as a locum, but will be starting officially as a member of our service in the next coming months. So she comes to Vancouver from Saskatoon, where she worked as a renal and transplant pathologist and served as medical lead for the Provincial Immunodiagnostic Laboratory, as well as clinical co-lead for the laboratory stewardship in Saskatoon. And she is a general pathologist who graduated from the program at the University of Saskatchewan. She then did her clinical fellowship in kidney, liver, and transplant pathology at the University of Alberta. And she has her PhD in immunology and has worked in academic and research settings for many years, both inside and outside of Canada. And her research was mainly focused on translational aspects of immunology and immunopathology. So she's going to be a wonderful addition to our group, since she has this depth of experience in immunology. She's also tremendous at quality assurance, and she has done quite a bit in her short time here already, regarding quality assurance in our laboratory. And in particular, she is focusing on electron microscopy and really working on building our electron microscopy program, not only for renal pathology, but also as a provincial service. And as Adira mentioned, I'm the current secretary of the Renal Pathology Society. So just a quick plug for some of the upcoming items. So the Renal Path Society, as in association with GlomCon, has an ongoing webinar series. And this year, the first half focuses predominantly on digital pathology, machine learning, and these aspects of where pathology is going. And this Sunday, there's a webinar on pathomics and next generation pathomics by Peter Boer, who also has an ongoing collaboration with Sean Barber and Namazi Riazi as well. Also upcoming, there is a hybrid meeting for the RPS annual satellite meeting, and this year the focus is update on crystal-associated kidney diseases. And there's an online option for both members and non-members, and membership for trainees is free. And there's a focus not only in native disease, but also primary hyperoxaluria in kidney transplantation. Okay, so quick plugs over. And now a bit about what has happened in the lab in 2023. So I'm sure to no one's surprise, the biopsy numbers have progressively been increasing over the past decade. You can see the total numbers for BC as well as our monthly average increasing. And for 2023, we hit a new high of just over 1,700 biopsies with an all-time high monthly average. And this increase is steadily ongoing, and we are working towards increasing our FTE as well as our capabilities in the lab. So there were two down points during this trend. First, due to the shutdowns due to COVID, and then a second due to the staffing issues associated with everything opening back up. However, I think the upward trend towards 2,000 biopsies per year is very clear. And looking at the breakdown of the past 5 years, you can see the total cases, but then the breakdown from native versus transplant. Over the past couple of years, it's been rather consistent, where it's about 65% native, 35% transplant, though this past year, the bulk of the increase has occurred within native disease. And then looking by health authority, many health authorities have stayed consistent over the years, such as Children's, Northern. The percentage has been rather consistent, but the biopsy numbers keep increasing. Vancouver Coastal, to no surprise, is the largest area where biopsies do occur, and then VIHA also staying rather consistent. But the real increases have been happening with and Fraser Health, as well as in the interior. You can see that Fraser is at an all-time high with quite a large increase in the overall percentage of the total biopsies performed, as well as a steady increase within interior. And you can see the trends here, where again, Fraser Health, rather consistent, but quite a large increase this year, as well as the interior. And so not only do we track the biopsies, but we've also been working on a quality assurance program looking at the quality of these biopsies to make sure that we can always provide all of the diagnostic and prognostic information that both patients and the nephrologists require. And so this is looking the past 5 years on a monthly basis with a running P chart, looking at the percent of ideally adequate native biopsies, which is the total collection of 25 glomeruli or more. And right here in 2021, we started providing some feedback to radiology regarding the number of glomeruli that were being collected. And you can see that there has been an increase, though not necessarily as well sustained. And it's a little bit tricky sometimes because the province is very diverse. And from looking at the numbers before, where the biopsies are coming from, the number of biopsies that are performed, the frequency of biopsies, even per site, not just health authority, are very variable. So what we've been doing is making some changes on the province-wide scale, like with the with giving radiology feedback, but also going through health authority by health authority and site by site to address the unique challenges that occur at each site regarding quality. And so this has first started with Northern Health at Prince George. And this is mostly because the biopsy quality was recognized not only as an issue by pathology at our centralized lab, but also at the local lab in Prince George by the nephrologist there, as well as medical imaging. That basically nobody was really happy with the quality of what was happening because there were a number of biopsies, were enough biopsies that were either inadequate or suboptimal that required re-biopsy. And this put, quite a substantial strain on resources for the patients, for the hospital, and for everyone involved. And from our work with radiology, part of this was due to that there was no bedside evaluation at the time of collection. So in the collection suite, there would be no real-time review. The biopsies would be taken by radiology blind, sent to the lab, and anywhere from 30 minutes to maybe 90 minutes later, one of the pathologists would review the biopsy, divide it, and then pass it on. But by that time, if there was any issue with the collection, the patient was already gone. And so from speaking with pathology, due to the current lab allocation of resources, there's no additional staff available to go into the suite. And there was a lot of limitations to what the local pathology labs could provide. So all three groups of us working together, we developed a program where the radiology ultrasound techs who are present within the suite at the time of collection would evaluate and allocate the biopsy tissue at the time of collection. So we're not actually, there's additional work for the people who are present, but it doesn't require managing resources for additional people to be present. And so everyone was on board with this. Radiology in particular was excited at the prospect. And so one of our renal technologists traveled up to Prince George and spent several days there training the ultrasound techs, showing them how to use the equipment, explaining how to evaluate the biopsy tissue, what is cortex, what's a glomerulus, and how to divide up the tissue. And we're continuing to provide them remote support. And so looking at a P-chart for Northern Health, it's very difficult to evaluate because the numbers are very small. They do less than 100 biopsies per year, and several months are single-digit biopsy collection months. And this right here is the date that we went up and gave the training. So it's really hard to look at this in this way statistically. But if we look at the overall trends for each year, so instead of looking at single biopsy numbers, we're looking at the service as a whole, you can really see the changes that have occurred, not only over the last 5 years, but specifically within the last year. So you can see in 2019 and 2020, we had about 50% of the biopsies were ideally adequate, with quite a substantial number, unfortunately, suboptimal or inadequate. And in general, for the province, we're looking at trying to get these suboptimal and inadequate categories combined to 10% or less of the total biopsies collected. In 2021 was when we started providing the feedback to radiologists, and you can see here there's some small improvement. In 2022 was when we went up and provided initial training, early 2022. You can see that there's a bit of a decrease in the suboptimal. But then really in 2023, you can start to see the improvement as the ultrasound technologists become more comfortable with our continued support, where we're now looking at no inadequate biopsies were performed last year, only 5% suboptimal, 19% minimally adequate, and we're looking at 76% ideally adequate, where we were looking for a total percentage of 80% or more being ideally adequate. So it's really outstanding progress for providing full diagnostic and prognostic information for everyone in Northern Health. And so you can see, looking at total biopsy numbers, you see something similar, where the 2021 and 2023 numbers were pretty comparable, and you can see the increase from 45 to 59 total. And so we're continuing all of these quality initiatives, and we're looking to improve the quality with individual collection sites, because we appreciate that there are a lot of individual concerns about what's going on at each site. And so it is taking time, because it is a very large project to go through the whole province and to provide this, but we're slowly working through. And we'll also probably be looking to the medical leads for each health authority, because we're looking to collaborate with local hospital foundations so that we can provide a uniform province-wide remote system in order for our lab to provide biopsy evaluation support. So this would, really unify and kind of the dissecting microscopes that are used across the province, as well as a camera, so that people can connect with us with our lab remotely anytime there's a question about how to evaluate a particular biopsy, quality, and how to do the division of the tissue. And so our lab has also done quite a bit in terms of education in 2023, and we had quite a busy year that's still ongoing. So for the total of 13 blocks, we've hosted 16 trainees, and these trainees have consisted of nephrology fellows, transplant fellows, pediatric nephrology fellows, advanced nephrology fellows, anatomic pathology residents, and we've also had one urology resident. So we have been booked solid for the year, and then we are anticipating another solidly booked 2024 academic year. But Susanna is starting to take requests for electives for the 2024-2025 year, starting next month. We're happy to provide either 2 or 4 week rotations, whatever works within everyone's schedule. We unfortunately can only take 1 trainee at a time because of our space constraints, and we only have 1 microscope for the trainees. But we will take any trainee, medical student, or fellow, but we will give priority to the programs that have some mandatory requirements. But after that, whoever contacts Susanna first gets first choice. So for anyone who is interested, please email Susanna, whose email is up here. We've also been working on academic half days, both for general nephrology as well as transplant nephrology. And so for general nephrology, Susanna is working to establish an 8 to 10 lecture renal pathology track, where there are topics repeat and evolve every 2 years. And so for this academic year, there's 4 1 to 2 hour lectures. And similarly, for transplant nephrology, we're trying to cover the most common transplant pathology with 2 to 3 topics per year. And this year we've given 3 1-hour lectures. Our lab is also heavily involved in research, both on the pathology side as well as in collaboration with nephrology. And so you can see the short summary here of all the different types of projects that we've been involved with several peer-reviewed publications, as well as conference participation with industry. And there are numerous academic, grant-funded, and/or translational projects that are ongoing, 6 that are ongoing, 3 completed, and 2 that are going to be starting, as well as we're very active with supporting nephrology in various clinical trials, with 8 active and 3 under review. Okay, and so now a bit about what's going on in 2024. So we have a few things in progress, and there's some, we hope to implement them shortly, but there's a couple of pitfalls, unfortunately, when it comes to managing things within lab. So one thing that we're working on is the automation of immunofluorescence. So I don't know if everyone is aware, but currently all immunofluorescence staining is manual, which means that for every stain that we do, there's a technologist there with a dropper that has to add each stain, primary, secondary, do all the washes by hand, dry them, hand cover slip them. And so in terms of automation, there's a certain point where automation becomes more feasible because of volume, and we're essentially at that point. However, our ability to do this really depends on the receipt of new equipment in the general anatomic pathology lab, Once they receive their new equipment, their old equipment will then be passed on to our lab, which we can then repurpose for our needs. And this also goes for the development of various immunohistochemical stains, and in particular, what we're working on for looking at the various new antigens in membranous. So in order to do this, we also need dedicated stainers, which will inherit from AP once they get their new stainers. And in the meantime, we're also determining the best use of tissue, because for every biopsy we do, it's not feasible to do the 15, 20 various antigens that we can stain for, but exactly which ones to do, what order to do them in, and also how we'll even do it, because for some of these antigens, we're looking at 1 to 2% prevalence in PLA2R negative cases. So it's very few cases, and we would essentially have to stain our entire archive to find those that are positive. So in addition to this, we're also working on being able to have easy access to a nanostring encounter, particularly in the context of transplant nephrology. The BHOT panel is becoming increasingly a part of clinical care and quickly becoming standard of care. It's part of the BAMF classification system, and working with transplant, we're looking to be part of various clinical trials, looking at clinical validation moving forward, as well as a way to integrate this into daily clinical workflow. And additionally, we have our current electron microscope, but I'm sure you all remember the times that we've had unexpected downtime, that unfortunately one electron microscope to serve the province isn't enough. We really need to have full coverage, and that will also allow us to do a lot more in terms of research. And so we're looking at a space solution for a second electron microscope at the new St. Paul's. So the clinical space allocated to lab in the new St. Paul's is unfortunately not large enough for clinical operations, let alone a second electron microscope. So we're really now in discussions with CSRC to try and see about additional space, either on the clinical side or on the research side. And kind of all of that ties into some of the issues when it comes to our lab, because we are a provincial lab in terms of service, that we receive and review biopsies from all the health authorities, and they all come to our lab. But in terms of funding, our lab is a subset of the general AP lab at St. Paul's, which is part of PHC, where we're also involved with part of the operations for MSJ, part of Coastal, and then all over, and in general, the Ministry of Health. So it's very difficult for us to get renal pathology specific equipment in terms of major and minor capital, which is why there's kind of this shifting around of in collaboration with the General Anatomic Pathology Lab. And then kind of in the middle of all of this is PHSA, because some of the funding is PHSA regarded, some, all of our lab staff are all PHSA employees. And this kind of comes into play when I'm talking about the very large and next big project that's coming up in the renal lab, which is digital pathology. So this is really our biggest project that we have been working on for several years, but now it's really coming to a head in 2024 in collaboration with a larger provincial project through PHC. So when it comes to digital pathology, you know, it seems very easy on the surface that right now we have glass slides, we review them with the microscope. So for digital path, you just take that, scan it in the scanner, and then we review it in the computer. But the reality is that that's actually the easy part. And that's actually the part that requires the least amount of consideration. That it's really, we're creating a huge amount of data, and it's how to transfer that data, manage that data, how we store it, how we exchange it, and all of the infrastructure and how things work into clinical operations. Because a lot of early digital pathology programs have failed, because if you take the scanner, if scanning takes a minute or two per slide, it doesn't sound like a lot, but we scan with our volume an average of 80 slides a day, and it can go up to over 100. So if it's taking a minute per slide, how that's going to factor into when we can review, when they get scanned, and how we have to organize the lab. So we began really thinking about digital pathology back in 2019. So we were considering the scanners because there's a whole bunch of a wide variety of scanners on the market, and how they integrate with lab operations or how they don't, how fast they are, whether or not they do immunofluorescence or not, and in particular storage. So each one of these scanned images is several gigs a piece. So you can imagine it starts to accumulate quickly, just one day, 1 week, 1 month, and then several years. And right now, there's no regulation on how long we're required to store them. So slides, we're required to store them for at least 10 years. In reality, we store them indefinitely. But how do you manage an indefinite storage of such large files where you just keep accumulating and you never really get rid of them? And also image management. So it's very easy to scan a slide and look at it, but when you're looking at how to manage 80 slides a day, which pathologist, how you're managing all of these images also becomes part of that issue. And then again, how you integrate it into operations, because if we're adding several hours onto how long it takes to get out a preliminary diagnosis, that's something that's very important to factor in. So these are things that we have been working on and investigating on our own since 2019. And really everything kind of started to come together with an interest at the provincial level with PHSA in early 2022. And then finally in 2023, we were able to get the funds to purchase the high volume scanner that we currently have. And so that really enabled us to get the IT support and to put in a lot of these things in place to get all of this background infrastructure rolling. So a lot of what we've been working on is just how to build in the background infrastructure. And so we've done that through being able to expand and work on existing health authority digital infrastructure. And also we've developed a relationship with Microsoft that has enabled various storage solutions as well. And so with all of this together, with the interest of the province and PHSA, our renal path pilot is really being used to inform what's happening overall for digital pathology on the provincial level. And so, PHSA is looking at digital pathology on a province-wide level, which makes a lot of sense. We're not the only pathology lab, though we're a highly specialized pathology lab. And there's a lot of interconnectivity between the various health authorities, which we also participate in. And so it makes a lot of sense to have a provincial solution to make sure that these different digital archives aren't siloed and that we're able to have free exchange of slides and communication between departments and between health authorities. So PHSA is creating a province-wide reference architecture that everyone will work within. They're also determining the cloud-based system that's going to be used, though the final system is to be determined, looking at the storage solution, looking at what viewer software to use, and their goal is to purchase a system that will allow integration with each health authority lab information system, which is quite a lofty goal. And so they're also looking at the various slide vendors depending on individual site needs. The RFP just closed, and so we have all of the scanners that are going to be available to everyone in the province now. And PHSA was also awarded an Innovate BC grant to assist in funding the pilot projects for the testbed environment. So that means for us, with everything that we've been working on to date, we've been doing by scrapping together any resource that we can, but now there's going to be about $700,000 to allow us to develop this for permanent use. And just a bit, so we have a small team working on this. That's basically myself, the AP division head, operations, the department head, as well as our IT consultant. What we've also done a lot in collaboration with Microsoft. And so with Microsoft wanting to expand their presence within healthcare, they have provided us our own team to help us develop what we have to date. And this is basically what we have with the test bed and how it's going to look, that we're using the established Health BC network, where we have a fully integrated system now where we create the slides, they're scanned, they automatically will go up to cloud. We can all access through our BC Health network and our health authority address. We can access the PHSA Azure landing zone, where we're going to have various viewing softwares and various vendor viewing capabilities so that we can then view our slides, do our whole evaluation process, because we need to be able to validate the diagnoses on digital versus slides, and then we can move forward doing digital clinical diagnoses officially. So we're currently working on this. We're about to deploy our ability to look at the viewers and start our the process of validation. It's unfortunately not a short process. We're looking, it's going to take about 4 to 6 months to validate the fact that we can do we can make clinical diagnoses on images versus slides. But while this is going on, there's also, while our test bed is going on, we're also informing the PHSA provincial test bed, which will go on for 18 months. And in that time, they're going to solidify the cloud system, the viewer for the cloud system, and provide what's going to be required for provincial digital pathology implementation. So we're creating a system that we're going to work within. We hope that it will be similar to what PHSA eventually adopts, but whatever they decide to adopt, we'll be able to adjust. And so this is all important. It's not just kind of lab operations. It has a lot of important implications for nephrology as well. First of all, because of the images. So what being able to have digital pathology will do is it will allow us to have a digital archive, initially prospectively, but we will be scanning retrospectively as well. And so this means that we'll have immediate histology comparison between biopsies. We won't have to just read off reports, try to figure out what we're doing, and then wait while hopefully the slides show up from Iron Mountain. And we won't have to worry about that time delay. We won't have any loss of slides, breakage of slides, or fading of slides, which can also make comparative review difficult. And because everything's digital, it's not just that everything's immediately available, but we're also going to be able to have all of that information linked. So in the viewer, it won't just be, well, we'll have to search and find the other biopsy. Everything will be linked per patient. And we're also working with the vendors specifically to make sure that they can not only link different cases, but we can include immunofluorescence, EM images, radiology reports, other pathology reports, so that we have all of that information that we need in one location. And also, this links back to then biopsy rounds and review. So it's very easy to show current slides for review, past slides for review, and we can, with all the softwares, it allows for temporary links, which we can annotate and provide to nephrologists. So we can either do simultaneous review through the viewers, or we can provide links that then allow the nephrologist to look at our annotations at any time. And so all of this is available because of the easy access through health authority emails. And it also has a lot of implications for research. As I mentioned, the work that Sean and Mazi are doing with Peter Boer, it all ties in because right now, machine learning, AI, and how to manage all of these digital images is really on the forefront of what's happening in terms of pathology. And we're working with PHC Ventures and Integrated Health Informatics Data Lab in order to have an easy way for people to work with all of these images in a de-identified way. So for the Integrated Health Informatics Data Lab, we would be uploading to a particular system information and slides that were requested per appropriate IRB approved review. It will allow for people to use those images within that system. So we're not losing data. So if we send someone, and this is part of data management. So if we send someone like an SVS file for their research, it's essentially giving them a recut of a slide and how to kind of manage that distribution of information. This allows it to all occur in one location and de-identified and for limited use. And also with images, there's the possibility for future educational uses, such as the creation of patient-centered materials that uses images to help explain reports. And so all of this together, really, it's mostly about data management. And so for digital pathology, we're not just looking at it as a way of being able to view things digitally, but really it's the opportunity to have a full digitization of the entire pathology service at the time of the biopsy order. So the ministry is currently streamlining requisitions and creating provincial pathology requisition forms. So what we're doing at the same time is through our relationship with Microsoft, we're working on enabling a secure online pathology portal for provincial ordering. So it wouldn't require what's happening locally. It wouldn't require faxing us information. Everything would be available digitally. We would automatically create digital barcodes that would then link all the patient specimens that are collected at that time. And it would let us know when a biopsy was ordered, when it was actually taken, and when it was sent and when we received it. Because right now, even locally within St. Paul's, we don't know our lab doesn't know when a biopsy has been ordered. And if a biopsy is canceled for any reason, we also don't know. So if we're told a biopsy is happening, but it's canceled for whatever reason, we still wait. We have no way of tracking and knowing what's going on. So with all of this, we also want to do QI and timing all of these components to know what's the delay between when a biopsy is ordered and when radiology is able to do the biopsy for that patient, to really help with scheduling and to really know and improve the workflow completely around the biopsy system. And if this is all done electronically, we also hope to then have immediate connectivity with Promise so that we're not having to do manual entry, looking for faxes. As you all know, there's everything gets lost somehow within fax. So it would eliminate a lot of this. And additionally, once we have all of this data, we can truly have a system where we're looking at data as a whole and doing full analysis, that it's not just pulling out of Excel spreadsheets, that Microsoft has been training our staff in app development. So we're looking at creating real-time dashboards as well as data analysis so that we can say, like, on a Tuesday, this is how many biopsies are ordered for the province. Like if one particular health authority is having an issue with getting particular biopsies done within a period of time, well, when are they all being ordered? So this is the type of data that we'll be able to look at. And so really what we're trying to do is we're trying to create a comprehensive biobank, because pathology absolutely is tissue, but it's also data. And so we're looking for a way to manage and organize an integrated, comprehensive physical as well as data biobank. And so we're looking to, with digital data, we're looking at as an opportunity to include and expand the provincial physical specimen biobank. So with all of this that we're doing on the end of histology, we're also going to be connecting all of the tissue to that data. And right now we only have fresh frozen immunofluorescence blocks as well as FFPE paraffin blocks after clinical diagnosis. But those blocks aren't necessarily appropriate for all future studies. And so as we build this, we're looking to fully develop a provincial biobank that could include blood, urine, and additional tissue core dedicated for research. So this wouldn't exclude anyone's current biobank. What we are looking to do is, through the use of the Open Specimen Program, to manage virtually the specimen as well as what's going on with all of the data management. So specifically, so the UBC and Faculty of Medicine have Open Specimen, where it's a central program that allows for digital management of biobanks. And it meets all the security requirements, and the accessibility is quite straightforward. It's all done through the campus-wide logins through UBC. And so through the system, you can have a dashboard where you can look at how many participants there are, how many types of specimens, what types of specimens, and the breakdown and how that changes over time. There's also hoteling. So particularly for us, so it wouldn't just be that everything becomes one biobank under our lab. We can designate what specimens come from what site, what health authority. These can all be identified in these ways, so that allows for various access, and we can, it allows for easy management and for distribution. And through the web interface, with applying for the data that goes along with this, it's also very easy to provide data without patient information. And we're uniquely set up for expanding this because we have our system with the renal biopsy collection kits. Right now it's for tissue for diagnostic purposes, but we can add to it because we have an easy way at the various collection sites to transport to our lab. And so working on all of this development, we're starting out developing this for genetics and CKD, and I've been working with Mark to try and figure out a way to organize this and to get the ethics together and to slowly develop it, starting small. So we're going to create the infrastructure and the workflow with the defined purpose towards Mark's genetic program. And then once we have this infrastructure established, we'll expand it to all patients and for other uses like biomarkers, molecular expression, et cetera. And so Providence Research, I'm working with them to provide us with some staff to assist with this development, because it's not a small thing. It's not a small undertaking to organize, especially considering that we're looking at it on a provincial level. And so we'll start with blood and urine and eventually then have the inclusion of additional fresh tissue. And as you can imagine, it's a very large undertaking in terms of the ethics, because we're looking to cover every health authority so that we can truly have it be provincial participation. So the RAB process, although there's been efforts to streamline it on a provincial level, I think we all know the difficulties associated with that. And so we are starting small with St. Paul's and VGH, but then we will work to expand. And so as we work towards that, I will really require and hopefully have the assistance and the collaboration with nephrologists throughout all the health authorities, as well as the medical leads. And so wanted to leave some time for some questions.
Thanks, Mei Lin. So I think we're super, I don't know if everyone realizes how lucky we are in the province to have an integrated true provincial lab so that we can all learn and move things forward together. So thanks for the leadership on that. Sean, you have your hand up. I believe you have your hand up. Do you want to be unmuted?
Hey, Mei Lin, hopefully you can hear me now. Okay, perfect.
Yes.
Yeah, I'm intrigued by the success you've had in Prince George in terms of biopsy adequacy. We, anecdotally, I think we've had some problems at VGH in terms of adequacy. And what was the mechanism by which you achieved the improved adequacy of biopsies? Was it through better allocation of glomeruli to different samples through the number of cores that were taken, or did it actually require increasing cores in order to achieve adequacy? And if there was an increasing number of cores that were taken, was there any trend towards complication rates worsening by achieving that?
Yeah, so that's a great question. So really, I mean, we had the benefit that we had full buy-in from everyone who was involved. Like basically, nobody was happy with the situation, that the local pathology lab appreciated that they weren't able to provide the service that was required. Nephrology obviously wasn't happy. Medical imaging was also not happy because, you know, they're looking to not, you know, to not have to re-biopsy. And so everyone appreciated that it was an issue. So everyone was very open to working towards a solution. And really, it has to do with the quality of the biopsy taken, not an increase in the number of cores. So, you know, I mean, as you can see, there, you know, it's not perfect, because there's always some cases that are where the biopsies are very difficult, and this isn't covering that. But it's more that because the radiologists in the suite didn't have the feedback on what they were getting, you know, they were just basically taking them blind. And so it's a combination of being able to have that communication to know, do they have cortex? Do they have medulla? The ultrasound tech being able to say approximately how much medulla, so that we can kind of gauge, and cortex, so that they can gauge the angle to take the next core and how to manage the next core. But it really hasn't resulted in like taking 4 or 5 cores, not like that.
So if that's the case, then, you know, what can we do at VGH to improve the quality of the biopsies done there, through whatever training mechanism you use in Prince George? Can it be expanded to other sites?
Absolutely, it can be expanded. We have provided some of that training to VGH. It's a little bit different because in Prince George, there's a known and limited number of ultrasound techs that rotate through. And so we had a defined cohort that we were training and assisting and helping them to improve their skills. At VGH, I believe there's quite a large rotation that occurs, and it's who is available. And there's issues both with evaluation and the allocation that comes from VGH, and that is something that we can address with their AP division head. He's a former renal pathologist, currently GU pathologist, so I think that he would be open to discussing things that we can do. It's just a little bit difficult because there's been, I mean, the people who are receiving training need to be receptive to what's being said, and you know, it's been mixed in other places.
I believe Chi has his hand up too. Chi? You have to unmute. There you go.
Hello.
Yeah, very good. Yeah.
Oh, hi. Nice talk, Mei Lin. It's always exciting to see the potential that the digital pathology can do. I have 2 questions. Number one, before we get there, is there any intermediate step that let's say I have an interesting patient, I do want to see the slides, I want to share it with my patient. What's the sort of a less sophisticated way of doing it? Can you still send slides to me, email me? Is that possible?
So absolutely. So I think the best thing to do would be to call and talk to whichever pathologist, because, you know, depending on the situation, we can tailor, we can take pictures. I've done that for several nephrologists, that there have been not very many, but there have been specific patients that you know, that where images would help with something in particular, that they're with their understanding of the disease, they're, you know, kind of coming to terms with the disease, that sort of thing. And so we have done that. And it kind of depends what you need. I think that it's very difficult to say just, you know, give you the slide and have you talk to the patient. But we can, so what I've done is I've broken down a few of the points by with and created some PowerPoint slides, like this is a normal glomerulus and this is your glomerulus, that type of thing. Or another possibility, because I've done this not with necessarily with images, but for particular patients, I have spoken to them on the phone with the nephrologist in their office on speaker, and that is something that we could do via Zoom as well. In the United States, there are some institutions that have clinics run by pathologists where patients who are interested in understanding their histology, understanding their disease, are able to be connected with their case pathologist where they can discuss some of these things. So we could do that in collaboration on Zoom as well.
That's great. My other question is more of a fancy, sort of my own fantasy. Like we see chest X-ray, we see CT scan when we order them, right? Although I'm not a radiologist per se, but I always pretend to be one. And I look at it, say ICU in the middle of the night, I look at the slides, or not slides, you know, the image. I'm just wondering, what do you think there will be a day that we can be sent, those pathology slides can be sent to us for us to look at it, even though before you guys officially give us a report? Is there any possibility that we can get a sort of a sneak peek view on those slides?
So with all of these viewers, there is the possibility for sharing of images. So you can always share a link, but it's limited and it's all de-identified. Because I guess, you know, for us the big thing will be, you know, what's the purpose of all of the images and everything? Is it so that you have an understanding of what's going on? Is it for patient education? Or, you know, is it an interesting case that you're hoping to write up as a case report and you're looking for images? So, you know, it's hard because everything is digital and it's very easy to share, but it's all still diagnostic patient information that while, like, say if it's a case of diabetic nephropathy, you may not be able to identify a patient per their their Chymostil-Wilson nodules. There are a lot of diseases in BC that are very unique to individual patients. And so we also, that part of what we're working on is how to share all of these images in a way that's helpful for everyone, but doesn't compromise ethics and patient privacy and all of these issues. So I guess it would depend on what the purpose is.
Yeah, no, I think those are interesting points. And I think like working with the KPMP, the Kidney Precision Medicine Project, just to go back to they do have a little standard handout to the patient with the information as well as the pictures. And I think it would be nice for us to look and see what that model looks like and create a true patient facing simple thing that can be given, whether it's their actual biopsy or whoops, hold on.
Yeah, and I absolutely agree. And some of the difficulty is the way that pathology is distributed throughout the province. So technically, the program that we use for pathology reports has the ability to include images. However, we don't have that version. And the way these reports are uploaded into CST and distributed through Accelerus, everything has to be in very clear text form. Like when we use Henak Shanlan, we can't use an umlaut, otherwise we crash the system. If we use a tab rather than 5 spaces, we crash the system. So it's not currently set up to do that via reports. But again, because we have this idea of how we want to integrate and create a digital system using some of the resources that we have through Microsoft, that's something that we can develop, but it wouldn't be it wouldn't be integrated into the reports as you know now.
Thanks.
So it looks like Adira had to go on service. So Dave, do you have a question?
Yeah, hi. Can you hear me, Mei Lin?
Mhm.
I always find it interesting because we started that you started the talk going with all of this machine learning, AI, and what the future may hold, and then we sort of end with we have an old version of a system with an umlaut that crashes a system, and I find that very challenging to hear, right? Because it limits your and your team's ability to get out information that you wish. It also limits information that's provided to patients and providers. We're all familiar with patients who receive biopsies in different countries, and some better than others, and they come with papers with nice PDF files and a document and pictures and a description. And I do think that that's where we're generally trending. I do wonder as well, in some document delivery, I know we're delivered through Accelerus, but I've been noticing a lot more lately where there's, particularly at the BC Cancer Agency, where documents are uploaded from a PDF format that are, a hyperlink, and to sort of look at that. And I do wonder whether that's an easier way for your output to be more precise, where you could put the umlaut on and not crash a system.
I mean, it's been a struggle with CST just to get our final reports, the first thing that you see when you click on the report. Because for a while, people weren't being able to find reports because they could only find the prelim report saying that the local pathology lab had sent it to us, signed that out, but you didn't know that you had to go up and hit this very small arrow in order to see next, so that then you could see what the system considered an addendum to the main report. And the workaround for CST is not what you think it would be. So it's very unfortunate because a lot of these systems are not designed for or thought of for pathology workflow. And they only kind of come up with these problems after the fact. So I think, we want there to be a way so that everybody can get the information that's needed, but whether that's through whatever workaround we can ham-fist into CST, or if it would just be easier and more efficient and more user-friendly to have a particular, say, portal that we manage. Like, I know it's another system, but then it would be a way to order reports or order biopsies, get the reports, and have everything in a meaningful way that makes sense. That might be an easier way to go, actually.
Thanks.
Okay. Anybody else? Looking through. Tai Chi, do you have another question?
Sure, I can ask if there's no one
Okay.
around. I thought about work power, actually. For example, with all the sharing image and digital pathology, maybe one day all pathologists of Canada can look at and share the workload. Say one side of pathology department maybe got short of labor, like short of manpower. Maybe other province can help out or something like that. So so there won't be any delays. I'm just curious. Maybe that's one potential possibility in the future to share the workload among provinces.
It is, but it's also like a double-sided thing, right? And it's something that is being talked about in pathology everywhere, because once you bring in digital diagnoses, then, you know, you're talking about sharing the workload across Canada, but then it becomes, why do you need Canadian pathologists? And so it gets quite complex with who is able to sign out what for what country and for where. And it's not an easy or straightforward answer, because in some ways it could be helpful for places that don't have a lot of renal pathology resources, because it is a very subspecialized area. And even some areas in the world that do have renal pathologists don't have electron microscopy, don't have a lot of other things. But then it also becomes an issue of, while there are renal pathologists with expertise, that expertise comes with cost, and then things get very complex. So the possibility is there, but right now everybody is very, very, very cautious about opening that up, and so it's not.
Yeah, I understand. Yeah, thanks.
Mhm. Okay. I guess if nobody has any questions, looks like Adira is still on the phone, and
Apologies, everybody. I have to go, but thank you so much for a great talk, Mei Lin.
thank you. So I think that's it. And so thank you, everybody, for coming. And if anybody has any additional questions or has ideas for things that we can do, projects specifically, or anything else about what's happening in the renal lab in the next year, please don't hesitate to contact me or Susanna, Mazi, or Pune, anyone. Thank you very much.